Okay, today I'm going to take you on a very different trip, which is called optic atrophy. And basically, it's a misnomer because there is no atrophy here involved. And optic atrophy is not a diagnosis at all. As you can see, I have no financial interest being a neuro-ophthalmologist, but there is a very nice story with this slide. This is a young beggar in London with his cup and reading Marx Capital. You know, I have seen so many similarities with this young guy, so I put it into my disclosure statement. Okay, so I will start with an index case of a 50-year-old male whom I've seen lately and who was referred to me due to an incidental finding of bilateral optic atrophy on a routine eye exam. On examination, his uncorrected visual acuity in the right eye was fantastic, while in the left eye he was seeing only 0.4. His color vision, of course, in the right eye was perfect. It was not that perfect in the left eye. He had a left trace RAPD on the pupillary exam. And on the fundus, as you can see, he had bilateral pale optic discs. And his OCT RNFL showed an average thickness of 49 in the right eye and 36 in the left microns. So it was an optic atrophy, of course. As always, we ask questions these patients, and on additional history, he told us that at the age of 13, he was hospitalized in the same hospital for headache, diplopia, and blurry vision. And on examination, he had bilateral optic disc edema, a normal brain CT, visual field loss, and opening pressure of lumbar puncture of 210 millimeters. Interesting. Do we know the reason for his optic atrophy? Not really. Could it be post-papilledema? Could it be labors? Could it be post-AION? Could it be post-optic neuritis? I don't know, because I haven't seen him back. But with this, I would like to open the session of my talk on optic atrophy. So as I told you, optic atrophy is a misnomer, and optic atrophy is not a diagnosis. Optic atrophy is actually a final common endpoint of many disease processes that can cause loss of some or most of the fibers of the optic nerve, or it can be a congenital condition. It generally manifests as a change in color and structure of the optic nerve in association of visual dysfunction. And you probably all know the manifestations, which are decreased visual acuity, decreased contrast sensitivity, depressed color vision, RAPD, whenever it's unilateral. Whenever it's bilateral, it can be no RAPD. Visual field defect or visual field defects, and it can be central, it can be peripheral. And of course, additional findings like proptosis, strabismus, headache, and skin changes. And I just want to remind you that optic disc atrophy develops in about 6 weeks, sometimes more, following an optic nerve lesion. And while being solitary, the optic atrophy is a fast localizing sign. Now, the usual list of etiologies of the optic neuropathies that can convert into optic atrophy is very well known to you, of course. And I will repeat it, although we had all day been dealing with them. It can be demyelinative, inflammatory, infectious. It can be traumatic. It could be ischemic, hereditary, GON or glaucoma. It can be compressive, and that's the most frightening reason that we generally meet. It can be neoplastic, it can be infiltrative, it can be due to increased intracranial pressure, and it can be, of course, toxic and nutritional. Now, you all know that the correct evaluation of the optic atrophy is very, very important for the diagnosis of the ocular systemic diseases. And we as ophthalmologists should be very, very careful in not writing optic atrophy, but seeking the real diagnosis. We are aware of multiple classifications and subdivisions of optic atrophy, and most of them, which you use in your daily practice, can guide you into the correct and final diagnosis. I will give you one or two of the classifications of the optic atrophy, starting with what's called primary, secondary, and other optic atrophies. In primary optic atrophy, we all know that there is no antecedent swelling of the optic disc. The lesion is generally between the retrolaminar optic nerve and the lateral geniculate system. This is how the optic atrophy in this primary optic atrophy group looks. The causes are various. You can have optic neuritis. You can have compressive reasons, the classical toxic, nutritional, and hereditary causes. You can have demyelinative causes, traumatic causes. And remember that the temporopellar of the optic nerve can be due to atrophy of papillomacular bundle, and also that band atrophy can be due to lesions of the optic tract. Now, secondary optic atrophy is when there is procedure by long-standing swelling of the optic nerve head in cases like atrophic papilledema, for instance. The disc generally is raised, has a very dirty, white grayish color. The margins are poorly delineated, and the lamina cribrosa is obscured. You can find pattern lines, and there is sheathing of arterioles, and this is how it generally looks. Also, we can see secondary optic atrophy in cases like NAION or non-arteritic anterior ischemic optic neuropathy, papillitis, or neuroretinitis. There is also consecutive optic atrophy, which is caused by a disease of the intraretina and its blood supply. The causes can be central retinal artery occlusion, status post PRP or RP, retinitis pigmentosa, retinochoroiditis or myopia, and of course there is the famous glaucomatous optic atrophy, where you can find deep and wide cupping of the pale optic disc and disappearance of the nerve fiber layer. Very important is to divide the optic atrophies into the tempo of the presenting illness, and I'm going to give you some more examples, like laterality, like age. And let's start with the tempo of the presenting illness, where we have the acute onset, hours or days, in cases of optic neuritis, NAION or AAION, AAION being arteritic anterior ischemic optic neuropathy, traumatic optic neuropathy, and then you have the insidious onset in cases of toxic metabolic, nutritional, hereditary optic neuropathies. And in between, we can find the subacute onset in compressive optic neuropathies, inflammatory and demyelinative neuropathies. Laterality means you can have unilateral optic atrophy or bilateral. Unilateral generally goes with optic neuritis, NAION, compressive causes, traumatic causes for optic atrophy. And in bilateral cases, I would put atypical optic neuritis or neuritis, AION, glaucoma, which is a bilateral disease, toxic nutritional and hereditary optic neuropathy. And we have the age. Accordingly, we'll see that children most probably will be with hereditary optic neuropathies or nutritional deficiencies, optic nerve glioma. Adolescents will show Leber's hereditary optic neuropathy, MS, NMO, neuromyelitis optica. Young adults will show optic atrophy in optic neuritis, traumatic optic neuropathy, meningiomas, and older patients in AION, NAION, central retinal artery occlusions, hypertensive retinopathy, diabetes, paraneoplastic syndromes, and of course gender, where males will show us LHON or Leber's, traumatic and toxic neuropathies, females more common in MS, meningioma, collagen vascular diseases, Sheehan syndrome, and of course, in overall, optic atrophy is more prevalent in African than white people. And we have the smaller diagnostic tips that will help us in working up these cases. We all know that optic neuritis is a self-limited disease, but may recur. Compressive optic neuropathy is progressive, and it doesn't improve. NAION does not improve, while AION can involve the fellow eye. And that's the main reason to treat as early as possible. And of course, toxic optic neuropathy can be partially reversible. Now, we've been talking and discussing hereditary optic atrophies, and I didn't want to miss the opportunity to repeat it. We have the Leber's disease, which is, of course, maternally inherited with point mutations in positions 11778, 14484, and 3460. We have the DOA, or ADOA, as it's called in Europe. You know why they don't use DOA in Europe? Do you know?
Yes.
DOA is the abbreviation of dead on arrival.
Oh.
So we don't use it in Europe. We have in DOA two genes, OPA1 and OPA3, which encode inner mitochondrial membrane proteins, and three loci, which are currently known for DOA. And of course, we have the Wolfram syndrome, which includes diabetes insipidus, diabetes mellitus, optic atrophy, and deafness, which is a disease inherited as an autosomal recessive trait, all ending in optic atrophy. I cannot finish a very short review of optic atrophy without mentioning this disease. So we're talking about Foster-Kennedy syndrome, which is olfactory groove meningioma, first described by Foster and then Kennedy in olfactory groove meningioma, which is optic atrophy actually, and anosmia with contralateral papilledema. Of course, by the way, this is the olfactory groove meningioma. This is a disease caused by a meningioma, which is, as you can see, coming to a dimension of a grapefruit. And you have also the pseudo-Foster-Kennedy syndrome, where you have also in one side an old optic atrophy due to AION, and then on the other side a new AION episode, and it's called pseudo-Foster-Kennedy. There's a take-home message, by the way, in this short review, and I took it from the classical article of Andy Lee from 2005, and he was referring to a very concise work on isolated optic atrophy, and he started his recommendation by saying that it should be ophthalmoscopically diagnosed according to the color, loss of vessels and nerve fibers, and the clinical exam, while taking the history, you can generally come to the diagnosis in cases of prior optic neuritis, NAION, toxic or nutritional optic neuropathies, and hereditary optic neuropathies, or cases of post-papilledema optic atrophy. But if after the complete neuroophthalmic history and examination, patient is still undiagnosed and has an isolated optic atrophy, you have to proceed to imaging. And of course, we're dealing with an MRI of head and orbit with fat suppression, or CT, wherever it's contraindicated. And by the way, in his review, there were 20% of cases where the isolated optic atrophy had compressive lesions behind them. So those 20% cases are good enough to demand us to send those patients to do an imaging. Sorry. Not yet. Screening blood evaluation are not recommended. So there's no reason actually to send those patients to a long, long list of blood tests, but to go straight to do the imaging of CT, MRI.
Thank you.
Thank you.